Hi, and thank you for joining us for our educational webinar with Dr. Megan Morales, where we will discuss the latest on the safety of the COVID-19 vaccine for transplant patients. I'm Dan Kerrigan, and I manage PR marketing for VCU Hume-Lee Transplant Center. Now, before we start the presentation, please note that we will hold all questions until the end. Please feel free to drop any questions in the Facebook comment section throughout the event, and we will address them during the Q&A portion. Now to our speaker. Dr. Morales is Director of Transplant Infectious Diseases at VCU Hume-Lee Transplant Center. He provides direct care and develops clinical protocols for patients undergoing transplantation. Her team has provided safe and effective care of patients transplanted before and during the COVID-19 pandemic. Dr. Morales leads this clinical care effort as well as COVID-19 treatment and vaccination planning and processes for transplant patients. She and her family relocated to Richmond towards the start of the global COVID-19 pandemic and Virginia stay-at-home order. No doubt her medical specialty has certainly gained a lot of attention recently, giving the unique and specialized care needed by our transplant patients. Dr. Morales, thank you for joining us today. I will now turn the show over to you.
Thanks, Dan. I'm glad to be here with everyone today. So we're going to be focusing our talk today about vaccines in transplant patients. Next slide. So some of the things we'll be talking about today is even as a larger picture of why is vaccination important and what do we know about COVID-19 infection in solid organ transplantation. We'll talk about the currently available vaccines, some larger vaccine principles in solid organ transplant, some of the efficacy, safety, and timing data that we have, testing after vaccination, some of the society guidelines and considerations for candidates, as well as what to do after vaccination. Next slide, please. We can't readily talk about vaccines without first talking about viruses. So all coronaviruses are large enveloped RNA viruses. So the SARS-CoV-2 virus is the one that causes COVID-19 disease, and that was first discovered late in 2019 coming out of Wuhan, China. It spread via respiratory droplets. And there you can see some of our counts as of yesterday. Over 141 million cases worldwide and over 31 million cases within the US. The picture you see on the right is an illustration of the virus. And that's notable for our discussion today because of the orange sort of mushroom-looking structures, the pieces sticking off the surface of the virus. And those are the spike proteins. The spike protein is what binds to receptors on our human cells and something that you may have heard about in the context of vaccine targets. So vaccination is designed to help your body recognize and respond to these spike proteins to keep them from binding and infecting your body if you get infected with the virus. Next slide. So since the early reports of this unusual virus coming out of Wuhan, and certainly since the beginning of the pandemic, the transplant community has been working in parallel with other scientists and clinical researchers to understand the impact of COVID-19 in solid organ transplant patients. So these are some of the many key questions that have arisen, among others. In addition to looking at the impact of the virus, the presentation, the severity, and the clearance of the virus from transplant patients, any optimal treatment, including changes in immunosuppression. Now, more recent questions in the past few months are focusing on vaccine use in transplant recipients. And that's what we are exploring more today. Next slide. Okay. So looking at really why is vaccination so important? And that's because transplant patients were included in early priority groups for vaccination. The reason for this is because they're often at high risk of both getting COVID-19 infection and also having severe COVID-19 disease. So transplant patients may have a higher incidence or rate of infection because of more frequent contacts with the healthcare system, i.e. more chance of them being exposed. They might be susceptible to lower infectious dose of the virus, which we see with some other viruses. They might be more likely to have symptomatic than asymptomatic infection. And there's a high risk of infection for many candidates also because of the comorbidities that you see here listed as other risk factors such as diabetes or chronic kidney disease. Like the general population, though, we do actually see a full range of COVID-19 from asymptomatic infection to mild symptoms to severe disease that requires life support among our transplant patients. But having a transplant is a risk factor for severe COVID-19 disease. Many of our transplant patients may also have other risk factors as well, like diabetes, asthma or COPD, obesity, kidney or liver disease, high blood pressure, or type 1 diabetes, all of which are additional risk factors for severe COVID-19. Transplant patients are also more likely than the general population to be hospitalized. About 81% in some case studies have been hospitalized because of COVID-19, and about a third of those are going to the ICU, which is similar to some general population data. You can also have secondary infections that follow COVID-19 infection. COVID itself may alter and decrease your immune function, but also just by virtue of being hospitalized or having additional immune suppressing treatments, use of catheters or central IV lines, which might be necessary for care while you're in the hospital, but then some people can develop secondary infections related to these. So that could be bacterial infections like a UTI, pneumonia, or a bloodstream infection, a viral infection like CMV, or fungal infections like Aspergillus pneumonia or Candida, a yeast in the blood. Next slide, please. So with that in mind, our old adage, an ounce of prevention is worth a pound of cure. Next slide. And in terms of preventing COVID-19, there's several ways which we can do that. The first are the public health and hygiene measures that everyone's aware of at this point, the masking, physical distancing, and hand hygiene. The second is vaccination, which we're focusing on today. And then potentially there may be some medications to prevent infection after exposure in the future, which are being evaluated in trials currently. Next slide, please. So currently there are 3 vaccines in the United States which have received emergency use authorization from the FDA. And these use 2 different sort of mechanisms. The first is the mRNA vaccine, and these were the first to be approved for use. Authorized for use. They're not yet approved. So the mRNA vaccine is the Pfizer and Moderna versions. And those basically use the messenger RNA to deliver instructions to our cells on how to make a harmless protein, which, thinking back to that first picture, the yellow mushroomy spikes coming off. So it teaches our body to make that spike protein, which is unique to the coronavirus, so that our bodies can recognize and respond to it. Protein subunit vaccines are currently under research, but are not currently authorized in the United States. And then the vector vaccine that is currently authorized for use in the United States is the Johnson & Johnson version. And so that uses a modified strain, meaning a virus that is not the coronavirus and that cannot replicate and cause infection in and of itself. And that's the viral vector. So using that virus to get into cells to deliver those instructional materials that way for our cells to start producing those spike proteins. Next slide, please. And here you can see a picture of those mechanisms and how they're working. So on the left, you see the mRNA vaccine model where there's the piece, those green squiggles are the genetic material that's being delivered to the cell to instruct the cell how to make those spike proteins. Your body then recognizes that something is abnormal, these are foreign bodies, and will induce your immune system to learn how to recognize and respond to those, so that if you are infected or exposed to the actual COVID-19 virus, your body will know how to respond. On the right, you can see the viral vector vaccine. And so you can see there where the genetic material and the instruction code really is being delivered through another virus with the same end result of having your body learn to recognize that foreign spike protein and learn how to make antibodies against it. Next slide. So although this is a novel or new virus to us, there is a lot that we know about vaccination and transplant patients that we can apply here. The first is that, first and foremost, we know that our patients can be more prone to severe and prolonged infections with other viruses. And so again, prevention of infection is really of vital importance. We know that immune-compromised patients and transplant patients are less likely to mount immune responses after vaccine compared to the general population. And so optimal timing after transplant is important in giving the best chance of response to immunization. It's common to wait 3 months or even as long as 12 months after transplant before giving vaccines. And that's to allow someone's immune system to sort of equilibrate again and come to stable levels of immune suppression. The exception to this, though, is outbreaks. So classically, influenza outbreaks have moved up vaccination schedules where you might be waiting usually 3 or more months. You may move up to 1 month post-transplant with an influenza vaccine in the setting of an outbreak. There are also some other strategies that have been used to attempt to improve vaccine response in transplant recipients. So a key example is the use of high-dose flu vaccine compared to standard dose vaccine. Booster dosing is another attempt at sometimes to increase response, though this is less well established. Both patients and transplant programs are, of course, very protective of those transplanted organs. We give you medications to suppress the immune system activity so that the organ isn't rejected. And then with vaccines, we actually want to elicit an immune response again, the best response possible. So concerns about rejection are understandable. But multiple clinical trials, fortunately, have not found any link between influenza vaccination and rejection. And in fact, in one large study of over 51,000 Medicare patients found that influenza vaccine in the first year after kidney transplant was actually associated with a lower risk of rejection and graft loss and patient death. Next slide, please. Okay, so some of you may have been familiar with this study. It's still a preliminary understanding at this point in terms of the efficacy and response to COVID-19 vaccines in solid organ transplant or SOT recipients. We know that transplant patients are less well protected, but we don't know really yet fully to what degree. Many transplant centers, including ours, have seen patients coming into the hospital with COVID infection even after their 2 vaccine doses. And so many of you may have heard about this study recently in the news. And this is from the group at Johns Hopkins studying the efficacy. And again, this is preliminary after only a single dose of COVID-19 vaccine in solid organ transplants. But this study was really just such a great example of the ingenuity, the connectedness of the transplant community throughout the COVID pandemic. So the response from transplant recipients volunteering for the study was wonderful. And they were not only recruited through centers all over the country, but actually through a lot of social media networks and outreach, much like the Facebook event that we're doing. And so those patients agreed to have antibody levels measured either via a special kit for at-home testing or through standard lab draws. And so they looked at study data from mid-December to early February in 436 transplant patients. They had a median age of 56 years and were a little over 6 years out from transplant. It was roughly half and half between Pfizer and Moderna. The J&J vaccine, adenovirus vector vaccine, had not been authorized for use yet by the time this study started. And then you can see there most patients were on tacrolimus, a little over half on steroids, and the majority also on mycophenolate, which you might recognize as Cellcept or Myfortic, which that's kind of the most common 3-drug regimen for most transplant patients. So by a median of 20 days after the first dose, actually about 17 had a measurable antibody response. And they were less likely to have an antibody response if they were taking mycophenolate, which is really consistent with a lot of other vaccine data in transplant, if they were older or if they had received the Pfizer vaccine. Next slide, please. So I just want to remember and caution you here, though, that this really is preliminary data. And so this was only looking at 1 of 2 shots of vaccines that do require 2 shots. There were not serial measurements over time. They looked at the antibody response only, which is one way, but not the only way, certainly, to gauge immune system response. And so based on this, you should not alter your immune suppression regimen. And you should not stop your other preventive efforts like hand washing, masking, and distancing after vaccination. Next slide, please. So turning to side effects, it is normal to experience some mild side effects after any vaccination, though often people don't notice anything at all. An early study of transplant patients vaccinated through December and January with 1 dose of vaccine, either Pfizer or Moderna, found rates of fever and chills similar to general patient groups. And then some other common side effects can include headache, fatigue, nausea, or muscle aches. The majority did have local swelling reactions. 61% had pain. Lesser numbers had mild redness or swelling. Most of this will resolve within 48 to 72 hours. And importantly, there were no reports of organ rejection in that group. So serious adverse events and serious cases of COVID after vaccination, meaning they required hospitalization, are reported by healthcare workers to VAERS, which is the Vaccine Adverse Event Reporting System. But for any individuals being vaccinated, they can register with VSafe, which is an easy way to check in after your vaccine to report side effects just by text on your phone. Next slide, please. So turning now to more rare side effects, these are things which are too rare to be picked up in clinical trials and may only be seen in small numbers once the vaccine is in widespread use in the millions. And so one of the early ones noted was with the Pfizer vaccine when there were increased cases of anaphylaxis reported, including in patients who had no prior history of anaphylaxis. And so there were 21 cases reported among about the first 2 million or so doses that had been administered, with an estimated risk of 11 cases per million doses. The Pfizer vaccine is still in use, and you can see one of the headlines on the side there. I think that actually was the morning that I got my first dose, so I understand when those are the things popping up in the news that they can make us sometimes a little bit anxious about receiving our vaccines. But it's important when we do have these numbers to look at the overall risk and benefit. Looking at the Johnson & Johnson vaccine more recently in the news, there were 6 cases of cerebral venous sinus thrombosis reported in addition to low platelet counts. And that was 1 in clinical trial and then 5 in use post, among many millions of doses delivered. And so the estimated risk there is about 0.87 cases per million. Though for the last week, since April 13th, they have recommended a pause on that while they're investigating further. To put that into some more general context also, though, the blood clot risk of getting a blood clot with COVID-19 infection is far higher. So just in general patient population, the clot risk is about 1 in 1,000 people yearly. But the risk of getting blood clot and severe COVID-19 infection may actually be as high as 1 in 4. That is somewhat skewed toward a sicker population. And if you were to look at those with more severe COVID or in the ICU, those rates of blood clot will actually be much higher. Next slide, please. So turning now to timing of vaccines, these are a lot of the questions that we're getting from patients pretty frequently. And so when is the optimal time after transplant to get a vaccine? And so we're advising for our kidney patients to wait about 3 months after transplant, and for most others, 1 month. Treatment after rejection applies here often as well and can vary depending on what agents you've received. So this is not only center specific in terms of what immune suppressing drugs that they're using at transplant, but patient specific as well. If your first dose of vaccine was received pre-transplant, the second dose will most likely be delayed by about 4 weeks after your transplant to complete that. And that's consistent with what the American Society of Transplantation is recommending. After COVID infection, you can complete or start your vaccine once you've been told you can be out of quarantine and you have no ongoing symptoms or fever. If you have had COVID infection and got treated with either convalescent plasma or a monoclonal antibody infusion, then it's recommended that you delay vaccination up to 90 days after that. In terms of timing your COVID vaccine with other vaccinations, it's recommended to separate them by 14 days whenever possible, although this also needs to be weighed on an individual basis between risk and benefit of other vaccine needs as well. Next slide. So COVID testing after vaccination has been an area that we've seen a lot of questions, and this is really an evolving field as there are new tests and new types of tests coming out regularly. So there is no active virus within the COVID vaccine, so you cannot get COVID from the vaccine, and thus you cannot have a false positive PCR test where they're looking for actual copies of the virus. If you have symptoms that might be consistent with COVID after being vaccinated, so fever, cough, shortness of breath, diarrhea, chills, you should still get a COVID test. In terms of the antibody testing, it depends on what antibody is being measured. So you may test positive for spike protein antibody after your vaccine, and in fact, we hope to see that positive after. You will not test positive for all COVID antibodies, however. So if someone has a COVID antibody test that's negative, that may be a nucleocapsid, which would only be positive if you've had actual infection with COVID-19 as opposed to vaccination. We don't routinely check antibody tests after vaccine. It's not recommended to do so, and centers are not doing that. The reason is that that is only one way to gauge immune response to vaccination. And additionally, being antibody positive oftentimes may vary between test to test in terms of the actual level and, again, which antibodies they're actually testing for. And so while you may be antibody positive, it's not a guarantee necessarily that those are neutralizing antibodies, meaning protective at a certain level. And so those are not tests that we're routinely performing right now. Next slide. We've covered most of this here, so I think for timing, I won't reiterate everything. But suffice to say that both the Transplantation Society and the American Society of Transplant both had updated their guidelines regarding vaccination in transplant patients as of last month. And some of the main themes that they touch on are things that we've talked about here, that they do recommend that all transplant patients be vaccinated, and that's irrespective of any past COVID infection or antibody testing that may have been done for other reasons. Ideal timing is uncertain, but again, depending on what immune suppression regimen that you've received for transplant, if that has been anti-B cell, like rituximab, or anti-T cell, like antithymocyte globulin or alemtuzumab, then you would need to delay your vaccination longer, not for safety reasons, but again, for efficacy reasons, to give your immune system a better chance of responding. Candidates should also be receiving the COVID-19 vaccine, and they've also recommended prioritization for transplant recipients, which we've seen, and recommend that household members be vaccinated as well. Again, they recommend not to check post-vaccination titers for the reasons I outlined, that it may vary somewhat test to test, and also cannot give you the most complete picture of your clinical level of protection. Next slide. So I wanted to touch on vaccination for transplant candidates, since we've been mostly focusing on recipients. So by this time last year, in April of 2020, there had been concerns about poor outcomes in infected transplant patients. We had an ongoing lack of PPE and personal protective equipment. There were concerns about infection prevention in the hospitals and how to keep patients and staff safe. And there were reduced resource availabilities due to concern about ICU availability, medication availability, and other things. And all of that had a really profound impact on the number of transplants that were being performed. In the US, transplants were being performed at about half the usual rate. In some countries in Europe, that had decreased even more dramatically, 87% in Spain, 91% decline in transplants in France. Some others that even had lower rates of infection still saw a pretty dramatic decline. So transplantation in Australia had declined by about 30%. And those declines were associated with increased deaths while on the wait list. And so it was really quite profound. Fairly soon after that, we had been returning to pre-pandemic levels. And certainly in 2021, there's no concerns about that at this point. And all centers are really back to pre-pandemic transplant levels. Vaccine timing will not delay your transplant. So any candidate should be vaccinated. Ideally, we would love to see you fully vaccinated at least 2 weeks prior to your transplant. Again, just to give your immune system the best time of responding before getting new immune suppressing medications. But if for any reason you're vaccinated and then get a call a few days later, that will not delay your transplant. However, getting actively infected with COVID will delay your transplant for some period of time until you recover. Similarly, for living donors, if you have a living donor, they should ideally be vaccinated themselves if possible, but also to really continue to observe a pretty strict quarantine in the 2 weeks before your scheduled transplant date. Because if they are infected with active COVID-19, that will also delay your transplant. It's not known if protection will persist post-transplant or if you may need to be revaccinated post-transplant. That's one of the many things under study presently, and that we'll hopefully have more data about in the future. And then just to know that all donors are screened for COVID-19 infection as well. and through PCR testing as well as history, any chest or lung imaging, and vaccination history. Next slide, please. So looking at life after vaccination, so the CDC had recently updated some guidelines for fully vaccinated people, and you can see there's a lot of the activities that they expanded. What's important to know is that these recommendations actually do not apply to transplant patients or other people who are at high risk of severe COVID infection. And you can see with the yellow arrow there, even for fully vaccinated people, they do still caution them that if they're visiting indoors, should be still using masks, social distancing, and precautions around people who are at high risk for severe COVID-19 infection, and that includes transplant patients. And then a reminder also that your household members and close contacts should be vaccinated. Next slide. So hopefully you found this helpful today. Some of the take-home messages that I'd like to leave you with is that our transplant recipients might be at higher risk for both acquiring COVID-19 infection as well as developing severe COVID-19 infection. And so for that reason, it's really important to prevent COVID-19 infection, both through the public health hygiene measures as well as vaccination. COVID-19 vaccination is very safe. Mild side effects may be common, but COVID-19 vaccination is very effective in general, though probably less so in our transplant patients. And that's something that we're getting more data about on a rolling basis. The risk of not being vaccinated hugely outweighs the risk of vaccination. We don't recommend any follow-up testing after vaccination, and transplant patients should continue to follow strict prevention methods after vaccination. Next slide, please. There are some additional resources if you'd like to seek out more. And then I think we'll wrap with any questions.
Thank you, Dr. Morales, for a great presentation. That was fantastic. We will now open the floor to any questions, but before addressing the questions in the comments section, we'd first like to read a few that were submitted in advance for you, Dr. Morales. And the first question is the vaccine safe for transplant patients?
Yes. So that's sort of overwhelmingly the question we see most commonly. And yes, it is seemingly safe for transplant patients. It doesn't contain any active live virus, and we do avoid live virus vaccines in our transplant patients. So that's not the case with these vaccines. And then also we have not seen any reports of rejection related to the vaccines.
Thank you, Dr. Morales. Next question. If I'm worried about the vaccine, is it worth the risk?
So that's always something that we're happy to discuss one-on-one or through your coordinator. But generally, the benefit of vaccination far outweighs the risk of vaccination. Again, knowing that they're very safe vaccines, knowing that in general they're very effective vaccines, though we still have fairly preliminary data in our transplant recipients. But the risk of COVID infection itself is certainly far greater.
And as a transplant patient, I've already had COVID-19. Should I still get the vaccine?
So you should still be getting the vaccine even if you've had COVID-19 infection. You want to make sure that you're fully recovered, feeling better, not having any fevers, and you've been told that you can clear from quarantine before going in for your vaccine.
And then finally, from the pre-submitted questions, should patients waiting for transplants be vaccinated?
Yes, so it is important for transplant candidates, those waiting for transplant, to be vaccinated also. Again, ideally, we would do that at least 2 weeks before your transplant, just to give your immune system the best shot at responding to the vaccine. But we would not delay your transplant because of it.
Thank you, Dr. Morales. So now turning to questions submitted in the comments section. The first question is, does having IVIG treatment, that's intravenous immunoglobulin therapy treatment for patients with antibody deficiencies, affect COVID-19 vaccines?
So that's a great question. It probably does not have an effect on the efficacy of the vaccine necessarily. If you get immune globulin treatment specific to COVID, then it is recommended to delay your vaccine by up to 90 days, just as knowing that you have some passive immunity. But otherwise, IVIG treatment in general is not expected to have a significant impact.
Thank you, Dr. Morales, and appreciate that. And one final question from me, as it looks like we finished up the comments. You covered a lot, Dr. Morales. Thank you for your time. Just one, what is it like? Just acknowledging just your role in working with transplant patients. What has the past year been like for you? And acknowledging that we're asking this question of all times during April, which is National Donate Life Month.
Sure. It's been a very intense year for all of us. I can say that across the transplant center, and especially through certain waves through the winter. And so, I think we all, one of the real benefits of our work is that we do have such a close relationship with our transplant patients and their families. And so, trying to see them through and guide them through the pandemic has been intense for them, as well as for us at many times. But we're so happy to have that close relationship. And these are patients, who are used to doing things above and beyond the normal. And so they've really risen to the challenge this year also.
And maybe just one or two more final questions for me, Dr. Morales. What, as far as the past year, and acknowledging early on in the pandemic, it was a balance for some or all centers really, as far as transplantation and COVID-19, but also acknowledging that this is a life-saving procedure. What has that been like with this team, and acknowledging in 2020 the team knowing that each transplant's a life saved, ended up actually transplanting 459 organs?
Yeah. So we were in the beginning having daily calls among the transplant center leadership, just in terms of balancing that risk and benefit, and being very aware that there's an acute need for transplants to happen, but to happen in a safe way. And so I had given you some of the numbers, just looking sort of across the US and globally of that decline early on. But since that time, it's been, full speed ahead, both once we, had appropriate resources available nationally, and better understood really the transmission and a lot of the ways that we could keep our patients safe. So it's been exciting to see that. And then transplantation is something that, obviously really embraces the unknown and forging new directions within medicine and surgery. And so at our center and others, we've actually transplanted patients now post-COVID who have had COVID and recovered or may still be testing positive. And now starting to, get offers from donors who have had and recovered from COVID. And so there continue to be new questions coming up constantly that we're working on, that we're working closely with other transplant centers on.
And as there's one final question from me, is there anything you tell just the concerned patients at various stages of their transplant just journey, whether it's being just placed on the wait list, or just kind of walking through the process, but knowing that COVID-19 is really that present discussion? Anything you tell your patients just to allay their concerns?
Sure. I know, a lot of it can be one-on-one concerns that we can try to help people troubleshoot. And certainly for individual people, that might look like letters to their job, if there's some way that we can modify something for them, or they're able to modify something to keep themselves a little bit safer. But it really comes down to the basics of the masking, good mask quality, good mask fit, hand hygiene, physical distancing where possible, and avoiding crowds. And then we certainly have seen, we've been getting a lot of vaccine questions, and just reminding patients that COVID itself is really the thing to be concerned about. And I don't take any vaccine concerns or questions lightly in any way, but having taken care of a lot of patients with COVID, certainly we were thrilled to have a vaccine available and be able to offer it to people.
Thank you again, Dr. Morales. Appreciate your time. It's been a pleasure having you join us today to discuss COVID-19 vaccinations and transplant patients. We want everyone to know that VCU Hume-Lee Transplant Center is here to help guide patients through that vaccination process. And our team, led by Dr. Morales, is closely monitoring vaccine developments, distribution, recommendations for transplant patients. For more information about organ transplantation at VCU Health, visit vcuhealth.org. And also follow us on Facebook at VCU Hume-Lee Transplant. Once again, thank you, Dr. Morales, and for everyone who joined us today. Have a great day.
Bye-bye.